Hi, hello everyone. This is Dr. Vivek Goel, your nephrology faculty at DocTutorials. And today we have gathered here for a live session, which is specially going to cater to pediatrics and medicine residents, the people who are currently pursuing their MD, DNB residency in medicine and pediatrics. And we are here with a very interesting case of a very common electrolyte disorder that you will face day in and day out in your wards and in your ICU, that is hypokalemia. So, my motive of discussing this case is because we become often very mechanical while managing hypokalemia or hyponatremia sometimes, and we just tend to complete our work. That is, whenever we have a patient with a low potassium, we try to replace the potassium and we do not maybe sometimes think that what led to hypokalemia. But there are certain that may be true for certain common causes of hypokalemia, that may be diuretic induced hypokalemia, or maybe another drug induced hypokalemia, or maybe a GI loss induced hypokalemia, where you just stop the offending drug or treat the GI infection and you will be able to manage hypokalemia. But there are certain causes of hypokalemia, or for that matter each electrolyte disorder, that will force you to to exercise your cortex a bit more, and will you will have to go for certain special investigations and then bottom your diagnosis. So this is a very interesting case of hypokalemia, and if there are any doubts you can ask me in the live chat as well. So we'll begin with the discussion. So we have with us a 32-year-old female patient who presents to us with weakness of four limbs. Yes, yes, you read it right. Weakness of four limbs for 2 days, which is acute in onset. It is a painless weakness, started from the lower limbs, progressed to the upper limbs, and it involves the proximal muscles more than the distal muscles. So it is a, a weakness, that is quadriparesis, in a young female, a 32-year-old female, which is progressive, acute in onset, painless, starts from the lower limbs, progress to the upper limbs, and it involves a proximal muscle more than distal muscle. Now, because the title itself read an interesting case of hypokalemia, so maybe you are narrowing it down here is only, but as a medicine resident or as a physician, your task is to think about the DDs. My mentor used to always tell me that, Vivek, a great internist is not he who bottoms down the diagnosis, the provisional diagnosis at the very first onset. No, it is he who can think of as many differentials as possible. So, always broaden your horizons and always think from the broader perspective. Now, also important history being, there is no history of sensory system involvement. So it's purely a motor involvement. There is no autonomic dysfunction, no bulbar symptoms as of yet, and there is no cranial nerve involvement as of now. So this is a case which you will also be seeing in your neurology postings, in your neurology wards as well. And you are right, there was no history of preceding fever, diarrhea, or dysuria. There is no history of sore throat, so there is no history of infection as such. No history of heavy exercise or heavy carbohydrate meal, because there are some periodic paralysis that could lead you to think of a heavy exercise or a heavy carbohydrate meal. For example, the hypokalemic periodic paralysis, recent COVID-19 infection or vaccination, and there was no history of any animal bite. Okay. So even a neurotoxic snake bite could lead to paresis, quadriparesis. So that also is not a case here. There was no history of similar paralysis in the past. So it's not a periodic phenomena that happens and resolves. No history of diabetes, tuberculosis, COVID, or any major illness in the past. She had regular menstrual cycles and one pregnancy which was there, which was uneventful. Am I clear? So yes, try to bottom down the differentials. And I'm telling you, please don't think only from the perspective of hypokalemia just because you know it's hypokalemia. I'm telling you, think it's a common case that you see day in and day out in your wards. So, what are the possibilities? So, going from the commonality of the occurrence, a GB syndrome or an AIDP, a Guillain-Barré syndrome, is very, very possible in this case when a young female may not be having a preceding history of infection, presents to you with acute onset progressive quadriparesis from the lower limbs to the upper limbs, proximal more than the distal. So, yes, I would keep GB syndrome as my first possibility. But there are certain dyselectrolytemia as well that could cause such a presentation. Very important, hypokalemia. Even severe hyponatremia may lead to weakness, but not so severe. So these are just the possibilities. And hypophosphatemia also is a possibility. If it is very severe, it could lead to quadriparesis. Are you getting me? Good. So let's go to the examination. The examination of this 32-year-old female reveals that she's conscious alert. So her higher mental function is absolutely normal. The vitals reveal BP of 120 by 70, 96 per minute. The single breath count is more than 22. So it has yet not involved the diaphragm. So there is no respiratory weakness as of now. In the upper limbs, the proximal muscles have a power of 3 by 5 and the distal muscles have a power of 4 minus by 5. In the lower limbs, the proximal muscles have a power of 2 by 5 and distally of 3 by 5. So to say, there is more weakness in the lower limbs and more weakness in the proximal muscles. There is generalized areflexia. So it's an areflexic flaccid paralysis. That is hypotonia also. So it's an areflexic hypotonic paralysis of the lower limbs and the upper limbs of the proximal muscles more than the distal muscles, where there is no cranial nerve involvement, no sensory involvement, no autonomic involvement, plantar is mute, and there is no enlarged gland as well. So this is the examination. Now, after the examination, can you narrow down the diagnosis further? Can you think of any other differential? Please let me know. Now, when you investigated this patient, of course, the CBC revealed mild anemia, the liver function test was normal, the kidney function test was normal, there was slight hyponatremia, which of course will not lead to such weakness, but there was profound hypokalemia. So you know it was the hypokalemia that was leading to such a severe quadriparesis. The urine routine examination was normal. The patient was started on IV potassium replacement via central line at the rate of 10 milliequivalent per hour, and the weakness started to improve gradually after the potassium got corrected. Despite continuous replacement for 24 hours, the patient remained hypokalemic. So to say, this is usually the case when there is an ongoing potassium loss while you are replacing it. However, the weakness resolved significantly, so the reflexes returned, the tone of the muscles returned. So to say, it was the hypokalemia which was the chief culprit. And when you corrected hypokalemia, the weakness in the quadriparesis also was resolving. What is the next step? Now, the next step is to delineate what caused such severe hypokalemia. When you have such a severe hypokalemia or refractory hypokalemia, the first thing that usually comes to mind is maybe a concomitant hypomagnesemia, because you know unless you correct the hypomagnesemia, your hypokalemia will not get corrected completely. But the serum magnesium was normal. When you did an acid blood gas analysis, the pH revealed 7.3. So there was mild acidosis. Whenever you get acidosis in the ABG, your next task is to delineate whether it's a metabolic acidosis or a respiratory acidosis. So you look at the PCO2 and the serum bicarbonate and the arterial bicarbonate. If the PCO2 is high, that means it's a respiratory acidosis. If the bicarbonate is low, it's a metabolic acidosis. And yes, here there was severe lowering of bicarbonate. So it was a metabolic acidosis. Whenever you get a metabolic acidosis, your next task is to delineate the anion gap. You know the formula of anion gap. Anion gap is sodium plus potassium minus chloride and bicarbonate. Now, whenever you get metabolic acidosis, you need to calculate the anion gap. Whenever you get metabolic acidosis, you need to calculate the anion gap. So here you had a normal anion gap, which was only 11.5. So to say, this was not a high anion gap metabolic acidosis. In fact, it was a NAGMA, which was a normal anion gap metabolic acidosis. Now you know the causes of NAGMA. It could be diarrhea, it could be renal tubular acidosis, it could be certain other conditions as well, but there are usually these two common conditions that could cause normal and anion gap metabolic acidosis. When I did a urine pH, the urine pH was 8. So, despite being acidosis in the blood, metabolic acidosis, there was inability to acidify the urine. The urine pH should have been less than 6, should have been actually much lesser than 6. But here it is 8. So it is actually inability of the kidney to acidify the urine. So despite there being metabolic acidosis in the blood, there was alkalosis in the urine, which is very, very significant and which is very, very important. The urinary potassium was 56 milliequivalent per liter, which is pretty high. So in a case of hypokalemia, if your urinary potassium is high, it means that you are losing potassium through your kidneys. So it's actually a kaliuretic action of the kidney, which is causing hypokalemia. So it's a renal loss of potassium and it's not an extra renal loss of potassium. So by now, you have understood two things. That number one, the kidney is losing the potassium continuously. That is why, despite correcting potassium, it is again becoming down. And number two, the kidney is not able to acidify the urine. These 2 points you have understood. And if you understand this concept where the kidney loses the potassium and the kidney is not able to acidify the urine, so you know which channel is defective by now. I'm trying to give you the concept. Am I clear? The patient had normal vitamin D levels, and the ultrasound reveals no nephrocalcinosis or no kidney stones. No kidney stones. This is also important. Why? I'll come to you. Urine biochemistry showed normal calcium, uric acid of 16.3, phosphorus of 19.6, and there was no abnormal amino acid urea. So to say, there was no Fanconi syndrome because in Fanconi syndrome or global PCT dysfunction, there is loss of citrate in the urine, loss of sodium in the urine, loss of amino acids in the urine. So there is no PCT dysfunction. So the PCT is normal. The ceruloplasmin was normal. So it's not a Wilson's disease. And the slit lamp examination was also negative for the case of Fleischer rings. Okay. So by now, what do you have? You have a normal anion gap metabolic acidosis. You have a hypokalemia and you have alkaline urine. So these three itself tell you that you have an RTA. But sir, RTA could be proximal RTA, could be distal RTA, could be type 4 RTA. It can't be type 4 RTA because in type 4 RTA, there is hyperkalemia. Here you have hypokalemia. So can't be this. In 1 and 2, in type 2 RTA, there is PCT dysfunction. There is PCT dysfunction. So to say, you have in RTA type 2, you have amino acid urea. You have a Fanconi syndrome phenotype. So it is not there here. What is left is the PCT being intact. So you know that this is a case of distal RTA. So my diagnosis is distal RTA. So first, step by step, I understood that my quadriparesis was due to hypokalemia. My hypokalemia, I then investigated the cause of hypokalemia and I came to the next step, which is type 1 or distal RTA. And now my cause would be, why did the distal RTA occur in a 32-year-old female? That is my third challenge now. I have already crossed two hurdles or two challenges. Am I clear? So, what are the possibilities? Now, first of all, you know that the distal RTA or the type 1 RTA involves the alpha intercalated cells of the cortical collecting duct, which is the chief site for acidification of the urine, which has the proton pump and the K plus H plus antiport. Both the channels are there on the alpha intercalated cells of the cortical collecting duct, which secrete the proton. One secretes the proton and one secretes the proton in exchange of potassium. So if that channel is defective, this is the main channel of the alpha intercalated cell, and this is the lumen. So if this channel is defective, there will not be acidification of the urine. If this channel is defective, there will be no acidification and all the potassium will be lost in the urine. So the possibilities are, it could be idiopathic, it could be familial. Why familial? If there is an autosomal dominant mutation causing defects in the kidney anion exchanger 1 in the intercalated cell, in the kidney anion exchanger 1, autosomal recessive if due to defect in the subunits of the ATPase in the distal tubule. What could be a secondary cause? So there is another disorder, systemic disorder, that has caused defect of this channel, which was not familial. You have acquired it later, like an autoimmune disorder to the tune of Sjogren syndrome, autoimmune hepatitis or biliary cirrhosis, SLE or rheumatoid arthritis, certain drugs like ifosfamide, lithium, amphotericin B, ibuprofen, hypercalciuric conditions like hyperparathyroidism. That is why I said that there was no nephrocalcinosis, idiopathic hypercalciuria, vitamin D intoxication, sarcoidosis, and other causes like medullary sponge kidney, obstructive uropathy, and Wilson's disease. You remember, we have ruled out each one of them. So these are the causes, of which some have been ruled out and some are yet to be ruled out. And then we will go step by step to diagnose what is the etiology of hypokalemic paralysis due to type 1 RTA in this 32-year-old female. So there was no history of renal stones, diuretic use, steroid use, dryness of eyes, dryness of mouth, joint pain, oral ulcer, jaundice, rash, fracture. So literally, you do not have any point to narrow down. And trust me, this such type of patients I have encountered many in my life, where you actually can't narrow it down through history or examination, and you have to suspect, you have to have a high degree of suspicion, and you've got to send the relevant investigations, and then you will be able to diagnose the cause of hypokalemia due to type 1 RTA. And as soon as I sent ANA, it turned out to be strongly positive. The anti-dsDNA was negative, so it was not an SLE. The viral serology was negative. And yes, you had the anti-Rho, that the SSA, and the anti-La, SSB, which were strongly positive. And now you know this was nothing else but your Sitka syndrome, or previously known as Sjogren syndrome. So it was the Sjogren syndrome, which is a fair possibility in a young female who presents to you with a type 1 RTA. You've got to suspect this. Shermer's test was normal, but lip biopsy showed features of chronic sialadenitis. So, see, the manifestations of autoimmune disease are usually and can be dispersed over time. So, it may not be that every patient will present to you with the classical dry eye, dry mouth. May so happen that the first the patient presents to you with renal manifestation, and maybe later on, maybe months or years later, the patient will have dry eye or dry mouth. So, if you classify if you know the classification criteria of Sjogren syndrome, what do we do? It applies to an individual who meets the inclusion criteria, does not have any of the conditions listed as the exclusion criteria, and has a score of more than equal to 4 when the weights from 5 criteria are summed. So, what are the inclusion criteria? Have you had daily persistent troublesome dry eyes? Do you have recurrent sensation of sand or gravel? Do you use tear substitutes? Do you had a daily feeling of dry mouth? Do you frequently drink liquids? So these are basically the common symptomatology of Sjogren syndrome, and you've got to exclude the mimics of Sjogren's like head neck radiation, active hepatitis C, AIDS, sarcoid, amyloid, graft versus host disease, and IgG4 related disease. Our patient, of course, didn't have any of these inclusion criteria. So here, this is again the criteria and the way score. So the final diagnosis in our patient is Sjogren syndrome leading to type 1 RTA, which led to severe hypokalemia and paralysis in our patient. So the beauty is your patient will come to you with this last part. First of all, you have to narrow it down that this is due to hypokalemia. You have to investigate hypokalemia and find out that it's of a renal cause. Of renal, then which cause? Then it's, it's an RTA type 1. And RTA type 1 will have to investigate and you have to carry down the Sjogren syndrome. So when you hear theory, when you read theory in your textbooks, you will read the opposite approach. You will read the Sjogren chapter and you will know it causes type 1 RTA. But when you see a patient will not have Sjogren syndrome written on the forehead. Patient came to you with paralysis, which was due to hypokalemia, due to type 1 RTA, with the ultimate culprit being Sjogren syndrome. This is the beauty of clinical medicine. The patient was treated with oral steroids for 4 weeks, after which it was tapered. She was also maintained on oral potassium supplementation and alkali replacement because there was acidosis. Her potassium is normal and the tubular function is gradually improving. So, how does the kidney get involved in Sjogren syndrome? The prevalence of renal involvement varies widely from 2 to 67%. Chronic tubulointerstitial nephritis is the most common renal manifestation of Sjogren syndrome. So Sjogren syndrome is more of a tubulointerstitial disease. The glomerular involvement is rare. The clinical manifestation of the tubulointerstitial nephritis is type 1 RTA. You have nephrogenic diabetes insipidus, and there could be hypokalemia. And rarely that could be proximal RTA as well. So there could be type 1 RTA, nephrogenic DI, and hypokalemia, which are the common renal manifestations of Sjogren syndrome. The mechanism by which it leads to distal RT is incompletely understood. Some patients have been described in whom immunocytochemical analysis of the tissue of the renal biopsy showed complete absence of the H plus ATPase pump in the intercalated cells, which is largely responsible for the proton excretion. However, the immune injury, how it leads to this loss, is unknown. Another mechanism is the presence of high titers of an autoantibody against the carbonic anhydrase 2, which will lead to proximal RTA. Glomerular involvement, as I already told you, is less common. because the tubulo-interstitial involvement is the main culprit. If there is glomerular involvement, there is MPGN pattern or membranous nephropathy that could be there as the glomerular manifestation of Sjogren's syndrome. In fact, most autoimmune diseases will have these two common glomerular phenotypes. Am I clear? So I kept it short and crisp so that you easily grasp this topic. For more such videos, you can subscribe to DocTutorials. It was a pleasure discussing with you. If there is any doubt, you could text me, you could mail me. I hope you had a awesome experience listening to this, and let's all enjoy clinical medicine together. Thank you very much for your patient listening.
Recording stopped.